Hi, I'm Josh McDonald,
Hi, I'm Emily Kerr.
and we are Hand Therapy Academy. So, Emily's joining us for one more time, asking us a question as a staff member. Emily, what do you have for us today?
Yeah, my question for you today, Josh, would be when you are seeing a patient post flexor tendon, um, and you've noticed that as they scar in, they're starting to become pretty stiff. How long do you continue your therapy?
So, some patients aren't going to get stuck at all, and some patients, we had a patient who was doing great, and then around week 3.5 to 4, she came in and was stuck. And sometimes it's just spontaneous; it happens out of nowhere, and you're like, "Oh, we're tracking great, we're tracking great." Oh shoot, what went wrong? Nothing you can do about it. Nothing the patient can do about it. They get sometimes they're very emotional about it, and this is awful. What happened? So we start to step things up. And sometimes before we hit that 6 week mark, we're starting to do things a little bit more proactively because we know that they are internally splinting and they're scarring in. And so while we're not going to have them do like heavy putty work and carrying kettlebells and things, I'm going to start to work scar more assertively. I won't say aggressively, but I'm going to start to do more. We can usually track to see after 6 weeks when I can start to do more stuff and I can do like a little bit of putty stuff, those kinds of things. I can start to see that by week 8 to 10, hey, is this getting better? Are we like, okay, we had a little hiccup there, but we're on track again? Or are we really binding down? And and then we start to look at like static progressive splinting. We start to work at nighttime extension stretching because when we do an extension load, it does distal excursion of that tendon away from the scar. And when we do static progressive flexion, it works on all of the restrictors and variables that limit flexion, like edema and capsular tightness and scar bulk, all of those things. And then active pull through is proximal excursion of the tendon away from the scar. So all of those things are useful, and so we'll start pursuing those. And then we start to get in some questions when we're tracking our progress at week 12 to 14 to start to notice, like, are we seeing the changes we want to start to see, even if it's in small amounts?
Yeah, and at what point do you wait until that 12-week mark to suggest maybe it's time for a tenolysis, or at what point would you start to suggest that?
In general, I try not to be the one that starts that conversation. I want that to usually come from the doctor to say, like, I think you should have this because I want to establish a relationship with the doctor. And it's kind of me going outside my lane, right? Like that's not necessarily my call. I will educate a patient if I think like I can see like maybe that's the direction we're going to be headed. I'll spend some time talking with them about, there are other things. If they're really getting frustrated and they're just not changing, I won't bring it up unless I think that's a probability they're going to get that. And like, oh, there's this other stuff and they do this procedure. And then here's the therapy afterwards, every day for a couple of weeks. And then 3 days a week is this whole involved process. So I'll touch base with them on that around week 12. And that's usually about when they're going back to the doctor and then so they can have that like, hey, is this a possibility? But I'm usually reluctant to say, I think you should have this because I don't want to be the one that suggests a surgery that then goes poorly.
Sure, sure. You touched on it a little bit, but can you share what our rehab process is like for someone who is post hemolysis, and what does that look like in our clinic?
Yeah. I want to see that person ideally the same day as the procedure, if not the very next calendar day. I've come in on Saturdays for people who had to have their surgery on Fridays. I want to see them within 24 hours, if not same day. If their surgery's at 3 o'clock in the afternoon, they're not going to make it in. That's fine. But I want to see them right away, partly because they still have that nerve block in place and I can do movement without them being painful postoperatively. I'm seeing them every day of the week, 5 days a week for 2, maybe 3 weeks. At the end of that time, at the end of 2 weeks, that's when scar really starts to bog down. So I want to know that whatever the doctor got on the table, we're still getting passive range of motion and beginning to get some active without having to beat them up too much. I don't want to do no pain, no gain during that phase. I want to do I want to keep our range of motion. I want to do passive without significant overpressure, partly because I don't want to stress the wound, right? Like that is a wound that needs to be respected. So I don't want to just plow through it. But we've got to keep moving. The whole benefit of a tenolysis is, listen, you have new scar that replaced old scar, but I get to start working on it day one. And so until that scar starts to bog down at the end of that 2 week mark, the proliferation phase, I want to know that I'm getting as much as possible. And so when it does bog down, we're as far ahead of the game as possible. So we do 2 weeks of 5 times a week ish, 2 weeks of 3 times a week, and then off to 2 times a week from there. At the end of the 12-week mark from date of tenolysis, we kind of are where we're going to be. So usually we're 12 weeks post-op, and then we're kind of assessing where we're going to go from here.
Yeah, that makes sense. How many tenolysis would you feel like is enough tenolysis? And when do you suggest, after they've had one, is it time for a second one?
One is too many, right? Two, we really don't want to do two. Those tissues, because they had a surgery to repair their tendon. So that was surgery number one. A tenolysis is surgery number two. That means we've opened up that finger. The blood vessels are affected. The connective tissue is affected. Nerves are affected. Every time we open things up, now the doctors open things up, it's trauma. It is a not insignificant trauma to the system. So a second tenolysis is a third time of opening all of it up. And a tenolysis, we think of surgeries like being these delicate things. There's this tool that he scrapes along to debride away scar tissue. How does he know where scar tissue ends and the tendon sheath begins? It's when you first see tendon sheath. And at that point, maybe you've already taken a layer of tendon sheath off. Maybe the tendon sheath is gone, and so it's just tendon. And so you're beating all those tissues up. We really, really don't want to have to send a patient or see a patient go back for a second tenolysis. In very, very rare circumstances, we'll see a patient who's had a third tenolysis, and the expectation for outcomes there is really low. It's at that point, it's nothing else to lose. Maybe they are so scarred into flexion on maybe ring and small finger that they can't put anything in that hand. And you're as much hoping that they scar in a neutral cascade of flexion, not in massive PIP and IP and DIP hyperflexion. Maybe you're just hoping for, it's basically like, am I going for a fusion in a better position than a soft tissue fusion in a crummy position? So that's not ideal, but our expectations for outcome with each subsequent tenolysis are worse and worse.
Yeah, I like how you mentioned the idea about expectations, because I think, especially as a new grad, or when I was a new grad, um, the expectation for everyone is so high. I think, like, I expect everyone to have significant results and be able to use their hand as normal, and so I think having an idea of better expectations is helpful.
Yeah. And I tell patients that even going into their first tenolysis, when they're thinking about it, do I want to do it? The doctor mentioned this. Is something I should consider? They won't do it until the 4-month mark, maybe the 3-month mark if it's a extenuating circumstances. But I tell patients going into it, we have a discussion. Give me a ballpark number of how functional you are with your hand. And if they say, I have 20% function, it is awful. I'm like, okay, then you stand to gain a lot with this procedure. You have a lot of room for improvement. If that patient tells me, I'm 85%, then you have a very small amount of room for improvement, but look how much you have to lose. Because I'll tell you, there's 3 outcomes with the tenolysis. They're better, they're worse, or they're the same. And if they're worse or the same, then why bother? And so those other 2 possibilities are very real. We see patients all the time who come out of a tenolysis, and because of how their body scars, maybe they're diabetic, maybe they're just a heavy scar, they come out the same or worse. It's not worth it. And so we try to set those expectations early. Like, listen, you can do all the activities. You just want that full tuck under fist. You have a lot you could lose if this goes badly, and it can with a tenolysis. Or you come out the same, 12 weeks of therapy and another procedure later. Is that worth it? So I can't draw that line in the sand for them where I say, like, okay, at 60% of function, it's worth it. If it's less, it's not worth it. The patient has to decide that. I just give them that. What are you willing to risk losing? And if you can't do anything with your hand, why not? Go for it. Yeah. Maybe not a third time though. Yeah.
Thanks for sharing.
Yeah. All right. If you guys have questions about tenolysis or flexor tendons or anything else, reach out to us. We've got courses on a lot of this flexor tendon stuff. But yeah, reach out to us if you have any questions, info@handtherapyacademy.com, or you can find us on social media, and our handle is Hand Therapy Academy.